It's nice having friends, and I'm so glad to see so many of them here. And I also want to thank Dr. McClellan for setting the stage and context for the overview that I'm going to provide of the report that you'll be able to see after this event. I also want to thank him for providing a little buffer between the video and my talking, because I was just so moved. It was hard not to listen to patients' stories and not feel compassion and empathy. And so I'm just incredibly grateful to all those people who participated in the survey and also in this whole project, because I think we can't underestimate how much courage it takes to speak about your experience when you've been impacted by cancer. So just taking that moment to really express my gratitude to the people with the courage to speak up and talk about their experience. Okay. So let's begin, and I am going to use notes because I want to make sure I stay on point, and I've got to figure out how to work this here. Is it this one? I go down? Did it go down? I just want to make sure I have this.
If you want to use this, you could just do these two.
Okay, that's it. Okay. Okay. Quickly, I'm going to say this, though we all know it, I'm going to be emphasizing it, though, that over the next several decades, we are going to see more people than ever receiving a diagnosis of cancer, and more than ever, we will see people surviving it. People are going to be living longer and better lives. And with that, let me go down here, we're going to see with that increasing need and increasing costs from cancer screening throughout survivorship care. And what we can anticipate, what we see here is we can anticipate costs going from 2010, when we had around 125 billion in healthcare costs related to cancer, to about 175 billion just in 2020. So with all this, with the rising needs and rising number of people, we really have to be coming up with innovative solutions, and we started to hear about that with Dr. McClellan. We're also seeing that a trend that in a reduced number of people who are uninsured in the United States. A report just came out through the Gallup poll, which showed that, it's depicted here, that in the last quarter of 2014, we see a significant drop in the percentage of uninsured Americans in this country. So in the beginning of 2014, we had about 17% who were uninsured, and it dropped at the end to hovering just below 13%. And with that, that means more access to care, again, and more needs and more costs related to treating more people. In the backdrop, and sort of the headlines that that people are experiencing, right, that coming to individuals' attention, is really quite confusing and overwhelming. People are hearing about having to choose between different plans. They're concerned and feared. We hear stories about being concerned and afraid about copays, paying for copays, about paying for insurance premiums, and narrowing access to healthcare providers. And we heard all of those themes come up in the video. But despite these challenges, the charge is to meet this demand with high quality care for all patients. And this has been a theme that goes back to 2001, right? When the Institute of Medicine published its report, Crossing the Quality Chasm. And it remains a beacon even today toward ensuring that care is of high quality. And what does that mean? That it's safe for patients, it's effective, patient-centered, timely in delivery, efficient, and equitable across populations and geography. Those standards were set in 2001. Jump up to 2013, and the IOM again publishes another report, Delivering High-Quality Cancer Care. And again, the themes that emerged in the standard of care that was emphasized is that patients should be engaged and well-informed, and that care should be evidence-based, accessible, and affordable. And I really speak about these reports because they set the backdrop and the framework for the survey findings that I'll report on. And finally, the report that came out in 2008, which is close to our heart here at the cancer support community, is the cancer care for the whole patient, which really states what seems so clear to us, is that quality cancer care, comprehensive care, needs to incorporate these attention and care towards the social and emotional needs as well as the medical needs. If we really want to do a better job in improving the quality lives of patients and improve overall health outcomes. So with that backdrop, the goal of this study was to better understand the challenges people face in accessing care, whether it's access to insurance, access to providers, their availability, time, the quality of their discussions, accesses to services such as psychosocial care, and also really what were their concerns about direct costs and indirect costs of cancer care. In essence, patients' perceptions about access, both their challenges and their triumphs, underscore our shared goal of patient-centered care. It's through their collective voices that will direct future research efforts and ultimately inform policy discussions. So really quickly, we took a very straightforward approach in our first steps in understanding people's experiences. We conducted a cross-sectional survey of adults, 18 years and older. It was administered online, and in October 2014, our outreach really leveraged our online network, our Cancer Experience Registry, and if you don't know about the Cancer Experience Registry, I'll talk to you about it any time. It's our online initiative, which really provides the infrastructure to create a community in which we can collect data from patients and hear their voices, and now caregivers as well, so we can elevate the patient voice. Again, it can be used in an ongoing way. We can keep people engaged in telling their stories, so we can have our finger on the pulse, and when we have these discussions about how we can improve quality care. And also through our advocacy partners and through social and traditional media outlets. Broad strokes, the people who participated in the survey were predominantly non-Hispanic, white, and female. I'd also say that they were, on the most part, highly educated. Not uncommon when you do research online. If you looked at the type of treatment that they said they experienced, we said a range, and really at the top and really the most common treatments, and not surprisingly, chemotherapy, surgery, hormone therapy, and radiation therapy. While over half of the participants were in treatment, the other half were not, and the majority of them were in remission. But we also see, not only people are also seeking care once they complete treatment. There's the significant proportion are going for follow-up visits to the doctor. 61% are indicating they've got follow-up tests. We've got reconstructive surgery, people are getting rehab or physical therapy, and fertility treatment. So I guess the context here is, once you get a cancer diagnosis, the need for services are long-term and ongoing, especially when we think about long-term effects and late effects. Here we have the picture of the woman who participated in the video, who is, even though while she completed treatment in 1998, she has persistent neuropathy, and that is something which needs her attention and has a tremendous impact on her life. So we asked questions certainly about the type of insurance that people have. What we see, again, really reflects what we have the general population of people living with cancer in this country. We have close to 50% who are employer-based, have employer-based coverage. Another about 32% are covered by Medicare. We asked questions about whether they liked or disliked their healthcare insurance, because of course we're very interested in their satisfaction. And what was interesting, about 2 out of 10, so 20% said that they were not satisfied with their healthcare insurance. But regardless of whether they like their health care insurance or not, we see similar trends in their concerns, in sort of serious concerns about out-of-pocket costs, particularly as they relate to coinsurance, paying for premiums, and costs for medication. So whether or not they like their insurance or not, these are their top concerns. We were very interested in understanding whether, if we're seeing any shifts in people's access to the providers of their choice. And the preponderance of people said that they did not see a change in access to their providers in the last 12 months. However, we do see that 10% see less access. Of course, if I wanted, in terms of next steps, I personally want to understand who are those 10%. As important as it is to think about access to providers in the strictest terms, am I able to get an appointment with a provider? It's also important to think about the quality of the interaction between the doctor or the healthcare team and the patient. Patients who report good communication with their providers have better quality of life, lower distress, and are more satisfied with their treatment. So understanding the patient experience with each of these elements in terms of availability, time, and sort of the quality of the discourse, from the perspective of the patient, becomes even more vital with the evolution of personalized medicine. And so what we see here is about 20% said they did not have enough time with their healthcare team. And when I look at this slide, there are different ways you can look at it. I look at sort of the top topics, how satisfied, how much do people have conversation with their doctor about goals of therapy and risks and benefit of treatment. And so you can see this in two ways. Well, about 79% are saying they're having these conversations, but that means that over 20% are not. Okay? Over 20% of people are not having conversations about their goals of treatment and the risks and benefit of their treatment options. As I go down this list, the other things that really jump out to me is far fewer conversations. People are having far fewer conversations about the impact of treatment, the diagnosis on their work, and on their financial lives. Okay? Well, take those two together. We know without work, and the financial cost of treatment is going to have a tremendous impact on people's quality of life, and perhaps even some of the ways in which they sort of manage their healthcare decisions and make trade-offs. And finally, I also note here, only half are having conversations about clinical trials with their doctors. If we're interested in accelerating, cure and improving care and treatments, we need to be thinking about those conversations about clinical trials and taking part in clinical research. Of course, we're very interested in also understanding people's experiencing delays. Okay, we find that a proportion of patients are reporting delays in getting care, and again, I want to, using our imagination, what it means to be a patient, or be someone who caring for somebody, a family member. What does a delay mean? I'm very interested, actually. Again, I'm putting my cap on now as a clinical psychologist, what that experience is and what it means to a patient. When you're waiting to get a test, okay? And what we see here amongst those who were experiencing delays was, substantial proportion, almost 62% are saying they're having a delay in scheduling a test or a medical procedure. Okay, we're seeing delays in referrals to a physician or obtaining a prescription. We heard clearly on the stories in the video about concerns about having access to their doctors and, and particularly in light of network limitations. We heard how that impacts people's sense of trust on what it means to have to make that shift if you're told you can no longer see the doctor of your choice. And that's borne out again in the survey. We see that 20% of people are seriously concerned about having to switch doctors because of network limitations or having to switch the location or the clinic where they're being seen. And we also see that, 20% are saying they're very concerned about their ability to get a second opinion. Again, going back to the standards that were set by the IOM, just in 2013, or if we wanted to go back to 2001, if we're really interested in patient-centered care, these findings really sort of shed light about where we are with respect to delivering patient-centered care. So certainly, we're very interested in understanding people's ability to access medical care. And so what we see sort of, again, first blush is, 20% of people reported not having access to medical care. However, when we did further analysis, we saw that there was discrepancy amongst those with higher income. They have better access. Not that that's any surprise. But we also know from previous studies that people with lower income also have greater need. Now put this all together in a larger equation, in the larger context of growing numbers of people with cancer, more people insured through the Affordable Care Act, and how are we going to meet this growing demand for care, which really may be difficult in light of physician shortages and declines in community practices in cancer care. You heard somebody in the video who spoke about how she had to travel 3 hours to get the care that she needed, right? That's of concern. So we also look to try to get a picture at the kinds of services that patient wants. Certainly in the era of personalized medicine, we see a significant portion of people who are seriously concerned about their ability to have access to genetic or biomarker testing. Again, really important when we look at that in terms of sort of the new age of cancer treatment. Again, we see, people concerned about access to clinical trials. And I'm going to focus on having access. 20% are seriously concerned about not having access to the emotional support services that they need. And I'm interested in that, and I think we at Cancer Support Community are interested in that, because we know that people who are highly distressed, we know that people who are depressed have far poorer health outcomes, far poorer quality of life. And if we could only reach them, we know that with relatively inexpensive intervention, we can make a difference there. So here's some striking findings where we see, when we ask whether or not people have received social and emotional support, 71% of people are saying that they did not, okay? And I'm going to go back, quote John Sprandio. I think he's sort of the star today. I wish he were here. When he said that people are making decisions like consumers in a situation where the clinical stakes are high and the potential suffering of patients is substantial. So here we have people often making trade-offs because they are so overwhelmed, because their social and emotional needs are unmet, and that's going to have an impact on their quality of life and their health outcomes. And if only we, again, could reach them. We asked some questions around why they didn't receive psychosocial support. And again, this is another striking finding for me, is that over 55%, who did not receive services because they didn't even know that they existed or where to look for them, right? Another 22% said that they didn't receive a referral. And then even some said they didn't seek psychosocial support even if they wanted it because their insurance didn't cover it. Again, these findings affirm the need for collective efforts to incorporate distress screening, referral in cancer care, and to follow outcomes over time. And this is something that we at the cancer support community are very committed to. And now moving on to really looking at the people's experience with costs and direct costs. We know that cost of care continues to be a major concern for people facing cancer, with a wide range of impact on their treatment and lives. And what we see here is that close to 50% are paying more for health care in the past year than and again, that's concerning. And some of these costs stem from the cost of treatment, and some from indirect costs, such as loss of work, costs of childcare or transportation, and transportation to and from treatment centers. When we look and ask patients their top reasons for paying more, when they, why they're paying more, what they're paying more in healthcare, what we see is not necessarily so surprising. What we see is about 62% are saying they're paying more for insurance premiums. 47% are saying they're paying more for deductibles. And 28% are saying they're seeing more for treatment copays. So again, I don't think this is so surprising, but we begin to see where some of the reasons for this reported increased costs. We also ask people about their top concerns related to the sort of financial experience. And what we see, again, they're concerned about how they're going to pay for hospital pays, how they're going to pay for medication. Nearly 4 in 10 people are saying that they're seriously concerned about bankrupting their family. Okay? And under that, again, going back to this idea that this has an impact on the kinds of decisions and trade-offs that people make, where you see that people are going to be more likely to postpone seeing a provider. We heard that again in the video. That they are likely to postpone filling a prescription or cutting pills. We just presented something at ASH where we were able to show how the combination of sort of being highly distressed and having financial burden was really a very strong predictor of missing daily doses of oral medication that were key to people's health outcomes. We also can see that when people are operating under this kind of financial distress and concerns, that they may delay or forego diagnostic exams. Again, this has an impact on overall quality of life, on people's health outcomes, and perhaps on cost as well to the healthcare system. And these are the kinds of things that if we can be providing, and we know that if we can provide quality psychosocial support, we actually can make a difference in these variables. So what's next? Okay, future directions. There's always more. I really see this as really just our first steps in beginning to understand the patient experience around access. And so our next steps, of course, are going to be to monitor the direct and indirect costs of cancer and related care for patients throughout the trajectory of care. And in order to really inform decision making, right? We need to better understand the implications of cost burden in terms of the patient's emotional health and use of health services over time. We need to have a better understanding of the impact of the Affordable Care Act on the financial and emotional burden on patients. We need to identify and look for those subtleties of key elements of patient-centered care, such as the quality of doctor-patient communication and access to them. And finally, and we've already starting to embark upon this, we are looking to evaluate the impact of psychosocial distress screening and sort of integrated care into comprehensive cancer care and its impact on overall quality of care and costs. But most importantly, and in conclusion for me, moving forward, we need to continue to listen to the patients, to really hear them, and to follow them over time, and to make sure that we are asking the meaningful questions that is going to provide insight into improving and delivering high-quality care to those impacted by cancer. And so that's really the beginning of the overview. I mean, looking forward to hearing some of your questions, but also getting your feedback on the report, because really this was just meant to give you a taste of what's in it.
So there should be little note cards on your table, so you could either write your question down and we'll come around and grab those note cards, or if you have questions now, we'd be happy to have you ask those. Anyone? Yeah, Lois. Come to me, sister. Come to me.
You invade your personal space. It's really nice. Am I blocking anyone? Hi, I'm Lois Pace with the Live Strong Foundation. Thanks very much for the overview. I don't know if I should say fortunately, but sadly matches a lot of the research that we've done, obviously, in this area of costs of care, and so it's interesting to see, and we have a lot of work to do. We're also coming out with some data alongside ACS CAN and the Urban Institute that relates to the Affordable Care Act, so I wanted to mention that in the event that it's helpful for you in terms of the next steps. And you might have answered my question in this last slide, but I was just wondering, you talked a lot about concerns, specifically around maybe some of the newer issues with healthcare reform, like having to switch doctors and go out of network, or having issues with specialty drugs. So I just wanted to be clear, were those simply concerns, or were they founded in actual experiences, like we heard in the video, where people actually were accounting that they did actually have to change doctors and they couldn't actually afford the drugs? Or is that really solely a next step that you will then pursue?
So being that this is a survey, the question was framed in terms of how concerned were they about it.
So it's just about concerns? Okay,
right.
got it.
We don't. So a next step would be, have they had to?
Sure. Okay.
And I think in this coming year will be more interesting, because we know we're a year into it. That's what's exciting, that we get to do research over time.
Yeah, of course. And I'd love to compare the data, because we do have some data that's going to look more at that other question. So I think we as a community can all, as we're sort of gathering information, I think we can come together with a lot of that and tell a story, amassing a lot of that data. Thanks very much.
Thank you.
And I will mention, I'm surprised you didn't, that we do have some of that data in the Cancer Experience Registry. So Joanne's trying to be humble about the Cancer Experience Registry today, but we do have some of that, and we're happy to query that at any point in time. Yeah.
Hi, I'm Ellen Sonner from Cancer Care. Will you, or have you looked at this data by disease or by organ?
So great question. We have begun to look at some of it by actually, because a good proportion are breast cancer patients, and we've begun to look at some of the difference between breast cancer and actually between non-metastatic breast cancer and metastatic breast cancer. We're going to be presenting a abstract at the Value Conference.
Association of Value-Based
Yeah.
Cancer.
And so we had that up particularly. We're able to do it. I think we have enough numbers to begin to look at it between metastatic breast cancer and non-metastatic, which can give us some ideas. I mean, some distinctions.
And there are differences.
Oh yeah, there are
Very real
differences.
differences. Yeah. Okay. Anybody else? Yeah, Greg.
When I was a political science major, comparative government was one of our required courses. And it may be beyond the scope of this, but having spent 7 years in Europe working with patients and doctors and everything like that, this is a whole different language compared to what they're doing. And I think you would benefit, I think we as a nation would benefit a lot from many of their positive experiences. So for example, issues of cost are just not an issue in Western Europe. And yet that's such a huge issue here. So I would just suggest a comparative approach, if that can be incorporated in this in some way.
It's interesting you say that. One of our colleagues and advisors is Linda Carlson, who is in Canada, who did a really some seminal work about looking at the impact of integrating distress screening and psychosocial services to cancer patients. And what she found in their environment, in their system, is significant improvements in quality and reductions in cost. And so we were working with her, we're really looking to see how we can, in some ways, replicate that in the United States. Again, it's very different here than in our than in Western Europe and our colleagues north of here.
So this is all very exciting, so congratulations on this, and thank you for doing this work. I want to highlight, though, one important thing in this context of costs. Dr. Sprandio mentioned that he'd had a couple of cases. When was this? When was he taped on this? December. Okay. Where patients had opted to decline treatment because of the projected costs. Those stories are really, really important to document and bring forward into the policy discussion. ASCO actually is to be commended from my perspective on their initiative to actually have their members bring these cost conversations more forward in the decision-making process. When we advocate for patients being able to make informed decisions about their care, my feeling very strongly is that that includes information about the financial consequences for their families. Patients should be treated as adults who are capable of making the full range of complex, difficult decisions. Now, a corollary to that is that there are likely to be instances, just because of the deficiencies in our overall approach to care, where people are going to be making decisions which are very rational from an economic perspective in the context of themselves and their own families, that potentially could be very, very valuable. The gentleman from California was talking very eloquently about societal perspectives on taking care of people with health care challenges. Those stories then need to be incorporated into the larger public dialogue. And I would say specifically for the purpose of putting the advocates of the kinds of things I was discussing with Dr. McClellan on the spot about the consequences of their decisions at the policy level about how the healthcare system is going to be structured. Joanne referenced one of my favorite reports in this whole field of healthcare, Crossing the Quality Chasm, and its specific definition of patient-centered care, which is care that incorporates patients' preferences, needs, and values. I just recently was reviewing that report, and I'm almost done. And in that report, it uses that definition of patient-centeredness in the context of clinical care. But that definition is fully transferable as a concept for bringing patient voices forward into the policy arena and policy discussion as well. That patient voices articulating patients' preferences, needs, and values are very relevant in a model of patient-centered healthcare advocacy, in this case, advocacy for quality cancer care.